Welcome to All Home Care Matters, the show where we discuss all things home care, with discussions on important age-related matters and topics. Brought to you by Enriched Life Home Care Services, the #1 rated home care provider in Michigan by Top Rated Local.
Hello, and welcome back to All Home Care Matters. If this is your first time visiting us here at the show, we want to say thank you for taking time out to be with us today. We appreciate how valuable everyone's time is, and that's why we try and make each episode here at All Home Care Matters something that will hopefully matter to you. Today, I am honored to welcome back Dr. Jason Karlawish. He's the author of The Problem of Alzheimer's. Welcome, Dr. Karlawish. How are you?
Very good. Thank you. It's a pleasure to be back.
Wonderful. Is it okay to call you Jason, or should I call you Dr. Jason?
Jason's fine, please.
Or we could say DJ, Dr. Jason. You know.
And how should I refer to you?
Lance is fine.
Okay, good.
Yeah. All right. Well, welcome back. You know, the first time you came on, Jason, was because I came across your book, The Problem of Alzheimer's, which I cannot tell you how many times I've recommended that book for people to truly have a deeper understanding of where and why Alzheimer's is at today in society. It's a tremendous, tremendous book. I was fortunate enough that shortly after your first appearance here, you were doing a book signing at one of the university bookstores there in Ann Arbor. So I got to meet you in person, got a great signing from your book. But today we're going to talk about some different topics. First, I wanted to really dive into a better understanding of dementia risk and the new findings. The implications of the Nature Medicine study shows that the risk of dementia by the age of 95 is 42%. And I think people just take that for granted. The whole thing is, dementia is part of old age and natural aging, which we all know it's not. And what's so staggering about that statistic is it's double the previous estimates. And so what does this really mean for public health, and what are some of the prevention strategies?
Yeah, it was one of those results that it's interesting within my colleagues said, well, don't we know this? And the answer was yes, we know that the risk of developing dementia increases with chronologic age. What this study's headline grabbing result was precisely just what you said, Lance, which was how big the number is compared to prior estimates. Namely 42%. So specifically, they used a quality data set from a longstanding study looking at cardiovascular risk, albeit a population study. So I don't think it was too sweetened for people with cardiovascular risk, which is a risk factor for dementia. And these folks have been followed for years. That study's been going on since I believe, 80s even. And so they had some good data about longitudinal risk of developing dementia, with good ascertainment also of whether an individual developed dementia. In other words, close follow-up with clinical exams, chart reviews, et cetera. So the study had a lot of strengths to be able to capture dementia cases. And the result was rather striking, which was from age 55 to 95. If you live to 95, your risk of developing dementia is about 42%. So it's almost a coin toss. What was interesting were a couple sub-findings. One was that risk really took off after 75. So up until age 75, it was fairly static there, but not close to 40. But all of a sudden, after 75, the risk took off. And then the other key finding was that 42% was for the population. When they stratified on some core variables, gender, male, female, race, Black, African-American, not, and genes, they showed, again, not unexpected findings, but they showed differences based on gender, whether you were African-American, self-identified or not, and the ApoE gene. And what it amplified was, and this is getting to finally answering your question, is the biological and social determinants of dementia, which gets to prevention. In other words, you can't change your genes. And if you do have a copy of the ApoE4 gene, your risk is higher than if you don't. And you can't change your gender. and race, but behind gender and race in particular are social and life course determinants of well-being. And this is why the argument for the need to, focus not just on discovering drugs for these diseases, which we need to do, and we're making good success, but the focus on the need to prevent, identify, and intervene on social, behavioral risk factors for dementia was amplified by that study. And we could talk more about what those are.
Before we go on, Jason, when you were on 2 years ago, one of the questions I had for you was about the genetic testing for the gene. And you said you would always counsel people and you wouldn't do it necessarily just to do it. There would have to be some maybe risk associated with it, or you'd have to have good reason. Rationale, correct. Has your viewpoint changed on that at all, or is it still pretty much the same?
Well, yes and no. The ApoE genotype testing has certainly entered into clinical practice for individuals who have either mild cognitive impairment or mild stage dementia caused by Alzheimer's, because those individuals have the option of taking anti-amyloid therapy. But in order to better understand the benefits of the therapy and the risks, they should get an ApoE test, because if you are an ApoE4 carrier, the drugs have higher risk compared to non-carriers of small bleeds in the brain and swelling. So for that group of people, mild cognitive impairment, mild stage dementia caused by Alzheimer's, considering therapy, ApoE testing is really part of their clinical practice. Now, of course, what's happened is many of those individuals have adult children and or other blood relatives. And so ApoE testing is starting to creep into their lives. If you find out, for example, that your relative is a carrier, one or certainly two copies, and you're a blood relative, there's a good chance you're a carrier. And so now ApoE testing has sort of become, well, I know it's in my family and I'd like to know. Well, then why would you want to know? What would you do with your data? Becomes a very legitimate conversation for people to have. So, we're moving into an era where I think ApoE testing is going to become more and more part of either things you ought to know if you're considering therapy, or things you may want to know because you value the information for planning your life.
Yeah. Well, and what fascinates me about that is, one, my grandfather did not have dementia, but he had colon cancer. Okay. He had regular colonoscopies, did everything, took care of his health, but he unfortunately did contract it. The surgeon had said to all the men, like his sons and subsequently now us as the grandchildren, are being told, when you get to 40, you want to start getting colonoscopies a few years earlier than the population, because there's a family history. Do you see that testing getting to the point like with the example I just shared, or is it?
Yeah, we're getting there. We're not just gene testing. In fact, more than gene testing, I think, is biomarker testing. So biomarkers refer to measures of the pathophysiology of a disease. Pathophysiology is a polysyllabic term for simply evidence that the disease is at work in your body. And we have the ability now to measure whether or not your brain has beta amyloid plaques and whether or not it has tangles of tau protein. And what's particularly exciting, revolutionary, challenging, pick your noun, is the ability to measure this with a blood test. And the test that's emerging is probably the one that will be part of clinical practice is p-tau217, which is just the name of a measure that captures whether or not an individual has elevated amyloid. And I can see a future where that test becomes part of practice in order to identify individuals who are developing Alzheimer's pathology and therefore should take an intervention to reduce the likelihood of that pathology developing. And I think p-tau is just the beginning. I think that the other markers of the pathophysiologies of the other causes of dementia will also be measurable. And one can imagine even getting a suite of biomarker measures at some point in one's life course to determine whether or not these diseases are developing. Yeah. And your history, and thanks for sharing it, Lance, the family history of cancer could govern the age of onset when people get that done. In other words, if there's a family history, if perhaps you have the gene, ApoE gene, maybe you would get this testing done at age 60, whereas if you're ApoE negative, you might wait till you're 70. I think these are all the kinds of questions are going to be worked out in the coming 5, 10 years. I have no doubt that this is where the field's going to go. Those are the questions we'll ask.
And I can imagine too, it might be more regularly, prescribed, if you will, if they had treatments. If you did test positive for carrying the gene, then we can do X, Y, more therapeutic intervention rather than just, okay, I have this information, what do I do with it now kind of situation.
Yeah, I mean, I think right now, again, there's genetic testing and then there's biomarker testing. They're very different. The genes are your genes since you were born. Biomarkers emerge as the disease develops. I think right now the argument to get gene testing, and I've had people who, want it and get it because they really see how it would change life plans. And these usually aren't medical type plans, but they're more life plans, like, how long they'll work for or where they'll live. They're in a debate. Do I kind of stay in this house versus move closer to the family? And some people value this information to help make those kind of life plans. Many don't. I think biomarkers are different, and I think many would argue that the value of a biomarker test needs to be linked to an intervention that will interrupt the pathophysiology. You can make the same argument, of course, around life planning. I mean, if I had positive p-tau 217 result, that would tell me dementia's coming down the pike sooner, and maybe I would make changes in my life plans as well there. But medicine as a practice is more comfortable with testing individuals if there's a medical intervention to do, because quite frankly, that's what medicine's good at doing. Medicine's not terribly good at life planning.
Right. Before we move on, just one last thing about the testing. About 2 years ago, we had a film director on, and she did a whole documentary called Tickety Boo, A Secret in Plain Sight. We were her first U.S. interview, and it's won a bunch of awards at the film festivals, but it follows her journey caring for her father, end stage of dementia, and then her deciding whether or not, and the culmination is her getting the testing done to see if she's carrying the gene. Fascinating film, and it really takes you into like what you're saying. People value it for different reasons, and they have different motives for wanting to know. Really fascinating film that really takes you into the more personal side of it.
Yeah, and again, I do want to differentiate between genes and biomarkers, and I want to make sure listeners come away with one very important point if they choose to pursue gene testing, which is before you get the test, what are you going to do with the result personally? And one of those, what are you going to do is who are you going to share it with, and who are you not going to share it with? And I think you need to think about that carefully, because people treat you differently when they know things about you, especially if the topic is dementia, whether it's caused by Alzheimer's or Lewy body or frontotemporal lobar disease or whatever it may be. People will treat you differently.
Yeah, and that's unfortunate, but it's true.
Well, in some sense, you'd like them to treat you differently if you're symptomatic because you want to be cared for. But yes, it is unfortunate, namely that they avoid and otherwise treat you as something less than the way you were before. No question. Yeah.
Thank you. So I wanted to talk about new Alzheimer's treatments. No better person to ask than you. Can you discuss the impact of the newly approved anti-amyloid drugs and their effectiveness, their risk, and what that may mean for the future of dementia care and treatment?
Yeah. So as a clinician working at the Penn Memory Center, a year and a few months ago, I was prescribing the same drugs I was prescribing for the last, 25 years. And then about a year and a half ago, the formulary at the University of Pennsylvania has included a drug called lecanemab. And in the last several months, a drug called donanemab was added to the formulary. And these are two new drugs that are approved by the Food and Drug Administration for the treatment of Alzheimer's disease. And both drugs have a similar mechanism, that is they target amyloid in the brain. And both drugs show that compared to getting a placebo for 18 months, persons on the drug show slower rates of change over time than persons on placebo. And those results are seen over a variety of different measures: cognition, everyday function, and ratings done by other people and ratings of other people, namely caregiver burden, for example, differs between people on drug or not. There's these measures called caregiver burden that were measured in at least one of the studies. And so what we have are two drugs that target one of the pathologies in the brain, and after 18 months of treatment compared to placebo, slow the pace of the disease down. They don't cure it, they don't flatten the pace, they don't reverse it. And those are new, and that we haven't had drugs like that. And it is a revolutionary event in the history of Alzheimer's. There's more to say about them, but let me make sure what I've said there is sort of, what questions do you have about what I've said there so far?
Yeah. So when you've seen the effectiveness of these two drugs and versus like people on the placebo treatment, are you seeing where they can take that information and the effectiveness of these two drugs, and then is the plan to then try to up that and increase dosages, or would you have to change the molecular makeup of the medication, or how do you build from there?
Well, I guess right now the standard of care is what you take one or other. The two drugs are called lecanemab, and the other one's called donanemab. Lecanemab is made by a company called Eisai, and donanemab is made by a company called Lilly. And a patient would take one or the other drug. You don't take both. The dosages are very well worked out. You don't adjust dosages on an individual basis, except for matters related to side effects. In other words, we don't increase the dose to get more benefit, for example. Lecanemab's dosing is fairly open-ended. The duration of the dosing is fairly open-ended, meaning this drug was studied for 18 months, and the company now has gotten approval from FDA for recommendations for what they call maintenance dosing, which is a less frequent, lower dose given continuously. In contrast, donanemab was studied and tested in a bit of a different way. They dosed the drug with periodic reassessments of the person's brain for amyloid, and if there was evidence that the amyloid was largely cleared from the brain, they stopped the drug. So if you're on donanemab, you have a follow-up, and measures of amyloid are performed, and if the amyloid falls below a level, you stop the drug. In contrast, lecanemab, as I've already said, has a prescribing recommendations that have one take the drug for an indefinite period of time. So those are two substantive differences. Having explained those, the magnitude of benefit, I think the most important question many would ask is, well, do they differ in the amount of benefit you get? And the magnitude of benefit between the two drugs, it's hard to do an apples to apples comparison because there were some differences in the severity of the patients in the studies. But essentially, they're fairly similar magnitudes of benefit. Namely, over 18 months of exposure to drug, you sort of set the clock back by about 6 months. Another way to put it is you reduce the absolute risk of progressing to the next stage by about 12%. These are all different ways to represent what's a hard concept for some people to, I think, get their head around, understandably, which is how do you quantitate slowing, like that it's not going as fast as it would have gone. That's a hard concept for people to get their head around.
As a physician, how would you determine which one of the two to prescribe to a patient?
I think the decisions from a sort of review of the evidence are largely based on the patient's preferences around the frequency of dosing, the side effect profile that they would face given their APOE genotype, and the duration that they'll be on the drug. I think that those are more patient choices, if you will, than physician choices.
Okay. Because I know, like Aricept, Numenda, any families that we would help, Jason, and they were on Aricept or Numenda, one of the things the physicians always told them, in my understanding, and please, you'd be the one to correct me if I'm wrong, it only helped about half of the patients that had taken it. There was only a therapeutic benefit to about half of the patients. So 1 out of 2, it would benefit. The other half would not receive any benefit.
Yeah. There's a substantive difference here between these drugs and Aricept or Numenda. So Within 6 weeks of being on Aricept or Namenda, the studies show people improve on their cognitive performance.
Mhm.
So
Okay.
you see the sort of jump up compared to people on placebo. In contrast with with lecanemab and donanemab, you don't see a jump up. You see that the curve of change over time changes its slope.
Okay.
We're getting into like geometry here, or linear algebra, I guess is. But in other words, it's not a benefit that you notice in the way you noticed the benefit of being on donepezil, where yeah, about half the patients will tell you I feel sharper, clearer, less foggy. Another half will say I don't notice any difference, and their relatives will sort of say the same thing. That's not the case with these drugs. They don't have that bump up because what they're doing is really kind of affecting a linear rate of decline more so than altering neuron function and therefore improving within about 6 to 10, 12 weeks.
Is before we go on, one last question because I just find this fascinating. So if a patient's on Aricept and they're one of the patients that are experiencing an increased sharpness in their acuity and their
Yeah, less
cognition,
foggy, et cetera, they'll tell you.
would
Yeah.
they be able to continue on Aricept and take one of these new medications?
Yeah, yeah. So in the studies that tested donanemab and lecanemab, not all, but many of the patients were on a cholinesterase inhibitor, which is the class of drugs within which donepezil, which is sold as a trade as Aricept, is, and many were on memantine, which is marketed as Namenda. There weren't analyses done that I can recall that looked at, was there an added benefit or downside of that combination? But to be honest, I can't see why there would be a downside to the combination, or frankly, any additional upside. It's sort of the therapies can be taken in combination or not. Yeah,
I know we talked a little bit already about biomarkers and detection,
yeah.
but how has the advancement in biomarkers, including blood-based tests and the other testing, changed the way that you're diagnosing?
Well, it's changed a lot. I've gone from being able to say to people, I think the most likely cause of your cognitive impairments and causing day-to-day problems with perception, cognition, mood are caused by Alzheimer's disease or caused by, well, in particular, Alzheimer's. I'll focus on, but that's only a probable. Now I can do tests that would say, yes, this is Alzheimer's. It's at least one of the pathologies present.
Yeah.
And I say at least one, not to be cynical or whatnot, or I'm not sure what that's the right word, but because many patients have co-pathologies, alpha-synuclein, which is a pathology associated with Lewy body disease and Alzheimer's, TDP, et cetera. My point, though, is I'm able now to do tests that can tell someone that they do or don't have Alzheimer's pathology in their brain. And I have had several patients uh, who have actually undiagnosed of Alzheimer's, and we can talk more about that. Namely, I said I thought you had Alzheimer's, but now that I've run these tests, you don't have Alzheimer's.
Incredible.
And this is a very different world than the world I was practicing in. It's had enormous consequences, I think, for patients and families, more definitive answers about what's going on. It's also had another very interesting consequence professionally. We're seeing a lot more physicians want to go into our field.
Well, I was thinking, back when you were here 2 years ago, you were saying how a lot of your peers in med school and things were saying, "What do you want to get into that for?"
Yeah.
And here you are.
Can't treat it, can't
yeah,
really diagnose it. What's the point?
yeah, yeah, and it seems to be one of the leading cutting edges of science and medicine.
Well, certainly it's been a leading cutting edge of science for a while. But I think what's happening now clinically is people are really taking interest. And I can say, I mean, I've chatted with some of my junior colleagues, and they said, I remember chatted with one guy recently, and he said, I was thinking of going into neurocritical care, et cetera. But, as I got to know what was happening in the Alzheimer's space, I got interested.
Yeah.
This last round of applicants for our fellowship program were more than we've ever interviewed in years past. And all this is good. I'm not complaining. I mean, I guess I could complain, where were you? Where were you, dear, all my life? But I'm a hopeful person, and I like to look forward as opposed to looking back and moping. It does say something about, though, bear with me, but who these new doctors will be, and they will be doctors who I think, their motivation is very much around the treatment and the diagnostics. That in no way says there's something wrong about them, but they're different than a doctor like me, who the kinds of treatments and diagnostics we had were different, and so the motivations for pursuing the field were different. That's not to say my practice and my approach is good and theirs is wrong, or vice versa. It's just to say there's a different kind of doctor entering into this space. I will now maybe make an editorial comment. I mean, my colleagues have observed that once junior doctors just determine that someone can't get therapy, they kind of lose interest. Like, well, no, what's the diagnosis? And so I do think it is an example of how, treatments drive practice. And I think in this field, we can never lose sight of the fact that the problem is dementia. Dementia is caused by many different diseases. And just because someone can't get treatment doesn't mean we're not interested in what the cause is, because the more I understand the cause, the better I can help you live with and the problems you're having and anticipate what's going to happen in the coming years.
Well, and I'm sure you've heard the saying, surgeons, they feel like a chance to cut is a chance to heal, right?
Yeah.
Well, in your field, you'd be the surgeon, but there was no chance to cut because there wasn't the options available. So you wouldn't have all these surgeons, but now that you can cut, now you're seeing them all come. Kind of the similar.
No, there's no question. I mean, medicine is a doing profession. It's a helping profession. That's a good thing, for God's sakes. I would be loath to not see it the other way. The question is how to help and what to help. And I do think that persons living with disabling cognitive impairments have a lot of needs in addition to an effective therapy, and the people who care for them do. And we don't want to lose sight of that, because short of a cure, where you essentially halt the disease, these are tough diseases to live with as things get worse. And we mustn't lose sight of the need to provide the care for those aspects of the disease.
Absolutely. Yeah, I want to talk a little bit about the GUIDE model and its role in dementia care for viewers and listeners that may not be familiar, because it's a newer program.
It is.
Would you share what the GUIDE model is and what your thoughts are on it?
Yeah. So I know this is being recorded, so we could go look up what GUIDE stands for, because I always forget. Let me do one thing right now, and then you can
absolutely
hang on. I'm gonna, because it's an acronym, and I really want to be able to hang on a minute. GUIDE.
Guiding an improved dementia experience, I believe.
Guiding an improved dementia experience. Yeah. Yes. Okay. So GUIDE stands for Guiding an Improved Dementia Experience. It's an acronym, therefore, for GUIDE. And GUIDE was issued as a demonstration program offered within the Medicare system for individuals who have dementia, so as to provide them or their caregiver education and training and resources to care for dementia, live with dementia. It comes out of the Center for Medicare Medicaid Services, otherwise known as CMMS. And I don't think the average listener knows CMMS. I wouldn't expect them to, but they ought to, after this podcast, know about it, because CMMS is actually created as part of the Affordable Care Act. And in the Affordable Care Act, CMMS was implemented as a means for Medicare to examine innovations in treatment, assess them, and potentially, therefore, add them to the Medicare benefit, et cetera, the Medicare insurance plan. Medicare is not a benefit, it's an insurance. So if we do appeal or otherwise overturn the Affordable Care Act, lock, stock, and smoke and barrel, and or otherwise eliminate CMMS, this program will go away. It's an 8-year-long project, meaning the funding for it, et cetera, is scheduled for 8 years. It has had enormous uptake across healthcare systems. We're one of many healthcare systems which signed on to becoming a GUIDE program site, because we recognized right away that one of the biggest gaps in care for people living with dementia and is education and training and support for identifying problems the person's having and coming up with solutions to address those problems, and providing some basic long-term services and supports, such as an adult day activity program. And GUIDE requires an assessment of patient and caregiver to determine what their needs are, and then a provision of those services. It's a tremendous advance. It's something that we've always wanted to have. We're a site for GUIDE. We're in the process of putting the program together. We're in the sort of phase one. You could do two different kinds of GUIDE. One was to get going right away. We needed some time to get the program up and running, so we're in the sort of two-phase model, if you will. But it's an incredibly exciting innovation being offered through the Center for Medicare and Medicaid Services, otherwise known as CMMS, which is part of Center for Medicare Services.
Do you know, you're one of the host sites. Do you know if this is just kind of like a pilot? If it's successful at UPenn, do you expect to see it get implanted at other university health systems and major health?
Well, yeah, it's already, I mean, like I said, it's all over the United States. In other words, most healthcare systems have are trying out GUIDE. I can't give you the numbers. I don't have them, but I will say that when I chat with colleagues, everyone's setting up a GUIDE program, and everyone is, of course, my limited little world. And I think it shows, though, the need and the interest in it. So we're, and I don't mean to be rude to my home institution. We're not in the forefront on this. We're in a setup phase compared to some other places that are in an implementation phase because they were farther along.
Like University of Michigan?
Yeah, I bet you Michigan's doing GUIDE. You can look it up.
I believe so.
So it's funded for 8 years, meaning unless something changes, though, after 8 years,
It's gone.
so we'll see. I give them credit for giving it 8 years, so we all can really learn from it, socialize ourselves to it, etc. 8 years is a long time in the arc of history. Boy, wow. And so we'll see.
Well, this is a good segue to my next question. Discuss the impact of the current executive orders on NIH grants and Alzheimer's research, because, that's been in the news a lot the last 20 some days. How is that affecting your research and across the board on Alzheimer's research?
I think it's too early to say across the board. I can speak anecdotally. I mean, several grants I'm involved in were not reviewed recently. Their study sections were canceled. So right now, those grants don't even have a review I can respond to or a score to determine whether or not they'll be fundable. I don't know yet whether they'll be reviewed. Some of the grants, I suspect, will have problems because there is an executive order that essentially requires removal of, not doing work that involves diversity, equity, or inclusion. It's a fairly broad executive order for that. But I've got grants where, and I'm involved in grants where some of the science involves organization of the methods and whatnot according to the framework of diversity, equity, and inclusion. That's the language that we used. And so if that executive order would suggest that those grants either can't get funded or that work in the grant won't be able to be done. What's frustrating, again, I'm speaking of my own work, is much of that work in those grants is around what also could be called recruitment and retention activities. So, we want to assure that the samples and the studies we're doing represent the population who has the disease, so that the results are generalizable. We need to explain the sources of variance, variability in outcomes. And to do that, you have to enroll a group of people that differ in various characteristics. And as I mentioned back to the beginning of our talk, lifetime risk of dementia is 42%. That risk is higher if you're Black African American compared to not. That risk is higher if you self-identify your gender as a female versus not. So there's a need scientifically to understand those sources of variance and risk. That's all just science. That has nothing to do with the ideology of diversity, equity, and inclusion. But if that ideological war that's occurring in America over the ideologies of DEI, anti-DEI, that war risks as a casualty the science of understanding the sources of variability in developing dementia.
Right.
And that would be a very sad outcome if that comes to pass.
Absolutely. And that'll affect people whether they're pro DEI, anti DEI, red, black, yellow. It doesn't matter.
It's maddening to think that, and I use the word ideology, the ideologies of DEI and anti DEI, I've used that word for both sides, are sweeping up scientific, are harming the ability to do science where the goal is to understand the sources of variability in outcomes to ensure that you can deliver the right drug to the right patient at the right time.
Yeah.
And unless things change, we're on this sort of, we're caught up in this, and it's right now, it's just, I mean, it's only been it's a little more than a month. So right now, the grants haven't been reviewed. Maybe they'll be reviewed, and we'll revise things. And it's early days, but if present trends continue, this is not going to sustain the field. The other concern is the impact on training, the impact on scientists getting their early grants funded to get their careers going. And I have several colleagues who are waiting on their grants to be reviewed, and these grants are going to get their careers going. Finally, we have word that many of the employees at NIH who were hired in the last 2 years have been let go. So the expansion of the workforce that occurred, particularly in the Alzheimer's space, where the workforce was being expanded because of the infusion of resources in order to address the vast growing problem of dementia, that workforce has just been set back by 2 years. That's not good for making progress. And I have a hunch this isn't just Alzheimer's, but name any other number of diseases in these similar. We could be having this similar conversation.
Yeah, it's like you get one step forward and you're taking 2 steps back almost.
Oh, 2 years back, I guess, in the case of
1 year. Yeah.
And I think as a country, we're going to need to start to have a conversation, and maybe it was overdue, which is, what kind of science do we need to solve the problems that affect all Americans? And can we separate those conversations from the ideologies around the DEI issues?
Right.
We don't have a lot of time here. If this present trends continue for the next 6-12 months, a lot of damage will have been done.
Yeah. Well, let's hope not, Jason. Transitioning to maybe a more positive question. Charles Piller wrote a book on called Doctored, which I'm going to be ordering. What are your thoughts on this book?
So Charles Piller's book, Doctored: Fraud, Arrogance, and something else in the Quest to Cure Alzheimer's.
Sounds like a companion to the problem of Alzheimer's almost.
Yeah, well, it's not. So Charles Piller is an investigative reporter for Science, and he has done some excellent reporting uncovering some rather shocking fraud in the Alzheimer's field. His central thesis of the book is that fraud has led to the production of useless, harmful drugs, the drugs that we've spent the last 45 minutes, part of the last 45 minutes talking about, namely lecanemab and donanemab. And that's where I think Charles Piller's thesis falls flat.
Okay.
In other words, I don't think I read the book, and he does not connect the dots between the fraud that he identifies and the claim that the drugs that are available are useless, harmful drugs, because he doesn't, and they're not useless and harmful drugs. We've talked about that. I don't need to revisit that. So, having said that, though, he does identify and talk about a host of very disturbing episodes of fraud and misconduct. Some of them are fraud and misconduct related to the development of the amyloid hypothesis. Much of it is work done in the basic science space. Early on, as much as that work was exciting, people had a hard time replicating it. So it was always work that was a little sort of interesting, but a hard time replicating. He uncovered some bad practices in journals in terms of peer review. A stroke researcher who engaged in bad practices, and unfortunately, the drug already made it into human trials. So who knows who, potentially individuals were harmed. So Charles tells a shocking story of fraud in the field because of selfish interests, private interests, arrogance, etc. But he does not, I think, make an argument that the drugs I'm prescribing at the Penn Memory Center are useless, fraudulent products. That argument, I don't. The book doesn't sustain it.
Is there a motive for him to go after the medications that are obviously, you would know are helping and show?
Motive is intention, and that's mind reading, and I would dare not try to read the author's mind.
Yeah. Okay. Let's talk about your latest article in op-ed in Stat.
Oh yeah, so that takes us back to the beginning of our conversation, which is the lifetime risk of dementia is 42%.
Yes.
And that's a call to action. We got to do something as a country. That number is too big to say, it's not a big problem. Whether as patient or caregiver, this disease is going to affect you either because you're a patient or a caregiver, or you're at risk of becoming one or both. So it amplifies the need to tackle the problem. And, I think the progress we've made in therapeutics, drugs, is very encouraging, but Alzheimer's is just one cause of dementia. There are other diseases that cause dementia. I think that the hope that we discover effective treatments and cures for each of them is just that. It's a hope. That's a great aspiration, but that's not a strategy. So what's the strategies we need? Well, drugs are one. The other is to go after the identified risk factors for developing dementia. And we've identified, science has identified 14 modifiable risk factors over the life course that lead to dementia. They explain about 45% of the risk of developing dementia. They begin early in life with education. And over the course of the life, add up: hearing loss, obesity, sedentary lifestyle, depression, diabetes, hypertension, hypercholesterolemia, lack of physical activity, air pollution. All of these contribute a few percent each to your lifetime risk of developing dementia. Every single one of them has a preventable strategy. I'll give you one that I like. In my city, for a period of time, I live in Philadelphia, there was an unfortunate habit by people to gather together with motorcycles and or cars and race around the city in packs. It was disturbing on a number of levels. They would sort of run through intersections and dominate streets. And the other thing they would do is they tended to do it at night. And so you'd be sleeping at night, and then you weren't sleeping because these cars would be roaring past. And it was a nuisance on a number of levels, but it was disrupting sleep.
Right.
And quality sleep is a protective factor for developing dementia. And so it's a good example of how there are many things we can do in our world where one added reason to do them is keeping your brain healthy. And so, when finally Philadelphia passed some ordinances, et cetera, that cleared the streets of these packs of cars and motorcycles, I'm glad they did it. I don't think it was argued as for brain health, but it had an intended or unintended consequence. And we could go down the list. In my city, we have a tax on sugary sweetened beverages. It was opposed by many, the nanny state, et cetera. But sugary sweetened beverages are a leading cause of obesity and diabetes. And obesity and diabetes, I just told you, are two of the risk factors for developing dementia. Now, I don't think anyone talked about the soda tax as preventing dementia. But again, it adds to the argument for why we need to do these things in our lives. You and I probably grew up in an era when you go to a restaurant and people smoked, or a bar.
I can remember that as a child. And
yeah, I still remember early when I lived in Philadelphia, there was a very nice pub I used to go to, had a great menu, but the sad part of it was you come home and you had to wash all your clothes because they stank.
Yeah.
And, we didn't think smoking bans were going to work, but they worked. And you know what? The effects are, on cardiovascular disease, cancer, and heart disease, and also therefore dementia. So, we can do these things in our world to make our world a brain healthy world. And my takeaway in that stat piece was just that we just have to muster the political will to take these steps. And maybe Secretary Kennedy, who's determined to help make America healthy, I think he has a preventive attitude about certain lifestyles and other exposures. This is something we could all work together as a country to address.
I hope so. And it'd be nice to see us all work together more as a country, as opposed as a country.
Yeah, if there's one thing that could help us do it, it's dementia. I mean, with a risk of 42% by age of 95, means you're either going to get it or you're going to be caring for someone with it. I don't care what your views on a host of hot button ideological issues are, but I think we can come together on this one.
I would hope so, Jason. Before we go, and I want to just say thank you so much. You're always so gracious with your time, and I just need to ask though, do you have another book in you coming out soon?
I am tinkering away with an idea. I like to keep the working title quiet because
you don't have to.
But yeah, it's another nonfiction book, and it's going to be in the space of thinking in a very forward, future-thinking way about how we're going to live with and care for either the risk of developing dementia, biomarker positive, or living with dementia. And yeah, actually, this morning before I switched over to email, I spent some time tinkering on some of the proposal ideas. So we'll see. A couple of years in the works, but yeah, we'll see.
Awesome. Well, also, I'd be remiss if I didn't congratulate you and your Philadelphia Eagles on the Super Bowl.
Thank you. That was a great game.
Yes. Do you want to also, real quickly before you go, share the UPENN podcast that you guys have?
Yeah, so I would invite everyone to continue listening to All Home Care Matters podcast. And while they're at it, also take a listen to the Age of Aging podcast. So Age of Aging is on season 3. And it's a podcast dedicated to helping people make sense of with how to live well with an aging mind. Obviously, diseases like Alzheimer's and Lewy body and whatnot are one of our concerns, but we think very broadly about, what does it take to live well with an aging mind? So it's on all the major platforms. Take a listen. The Age of Aging.
Well, thank you. And Dr. Jason Karlawish, one of the people I hold in the highest regard and esteem. I always appreciate catching up with you. Thank you again so much for your time today.
Well, thanks, Lance. It was great to be here.
Our pleasure. Bye-bye.
Bye-bye. Take care.
Thank you for joining us again here today at All Home Care Matters. All Home Care Matters is here to help families as they navigate these long-term care issues. We invite you to visit us at allhomecarematters.com, where there's a private, secure, fillable form where you can give us feedback, show ideas, or if you have questions. Every form is read and responded to. And remember, you can listen to the show on any of your favorite podcast streaming platforms or watch the show on our official YouTube channel. Just make sure that you hit that subscribe button so that you never miss an episode. I would also like to say thank you again to Dr. Jason Karlawish, author of The Problem of Alzheimer's, for joining us today here at All Home Care Matters. Thank you, and we look forward to seeing you here next time.
Thank you for joining us today. We look forward to you joining us again on another episode of All Home Care Matters. To learn more about the show and to connect with us, visit us at allhomecarematters.com.